Hi, everyone. Well, today we are gathering to celebrate the excellence in the field of limb preservation, a crucial aspect of vascular care that impacts countless lives across the globe. And it is my honor to present the award for Limb Preservation Excellence in England, a prestigious recognition bestowed upon a very well-deserving individual through the Global PAD Impact Awards by the Global PAD Association. This award recognizes outstanding contributions to the field of limb preservation in England, honoring those who have demonstrated exceptional dedication, innovation, and impact, a lot of impact, in their efforts to save limbs and improve the quality of life for patients with peripheral artery disease, or PAD. The criteria for this esteemed award encompass several key areas. Number one, pioneering advancements in limb preservation techniques and technologies. Two, significant improvements in patient outcomes and quality of life. Three, contributions to research and evidence-based practice in the field. Four, leadership, and a lot of leadership in multidisciplinary collaboration and team-based approaches to peripheral artery disease care. Number five, commitment to patient education and community awareness about PAD. And six, advocacy for early intervention. We know that's key. Early intervention and comprehensive care in PAD management. Number seven, mentorship and education of the next generation of limb preservation specialists. And probably the most important one, amputation reduction, proven amputation reduction. Now, the recipient of this award has not only met, but truly exceeded these criteria, setting a new standard of excellence in limb preservation care across England. So it is with great pleasure that I announce the recipient of the Limb Preservation Excellence Award for England, Dr. Nasir Ahmed, esteemed vascular surgeon from Manchester, England. Dr. Ahmed, please, thank you so much for joining us. Please, join us now to receive this wonderful recognition, well-deserving recognition.
Thank you very much for having me, and thank you for the award. I'm incredibly honored and proud to have this prestigious award. As you're aware, our main work, we've been working really hard over the last 6 years in our pilot area. We're doing a program called the Manchester Amputation Reduction Strategy, or MARS, and our headline figure is that we've reduced amputation prevalence by 46% within 6 years within our pilot area of 220,000 people. And now we're scaling it up to over 3 million people across not only Greater Manchester, but in other parts of England as well. And our work is built from both the ground up and also from a top-down approach as well. So we're working with patients, we're working with managers of services, we're also working with podiatrists and nurses, as well as commissioners and local politicians. And within England, we've got a new education amongst the what's called the ICSs, the Integrated Care Boards. They're now responsible for care in localities across England. And we're working with several services to put amputation reduction and wound care right at the top of their priorities. And that we've achieved that within Greater Manchester. So the whole system is looking to improve wound care and have amputation reduction as their primary marker, as well as what many of these patients die from, which is cardiovascular disease, respiratory disease, diabetes, and cancer, putting all these as priorities. So I'm incredibly proud of the work that our team has done. We've done huge work around implementation science or knowledge mobilization, because many people know what to do and many of the services know what to do. And the evidence is very clear what needs to be done. The problem is not lack of knowledge. The problem is implementation. And using implementation science principles, which is often just talking to people, getting people to know each other, getting teams to know each other, getting teams to work collaboratively, and to know what the patient journey is like, and standardizing that care with a huge priority on prevention. I think all these things coming together, and it's all about the aggregation of marginal gains. And what we've proven is that is what works. And we've now got the results. I say after 6 years of hard work, particularly through COVID as well. Our headline figure has just been published in the Diabetic Foot Journal. We're proud of this, and we're getting incredible amounts of funding as well. Particularly, we've had 4 grants awarded just in the last month alone, which will hopefully allow us to, progress our work across the country.
Your journey into medicine was a little unconventional. So, how has this unique background influenced your approach to limb preservation and addressing healthcare inequities?
Well, you're absolutely right. My journey into medicine wasn't normal. So I was born in England, in a place called Birmingham. I didn't learn to speak until I was 5 years old. For my GCSEs, or sort of when I was 16, I failed my exams, particularly for A levels as well. I managed to scrape my way to get to do a degree in physiology. And that's when my life changed. I met certain doctors and professors when I was doing my degree in physiology that were working within epidemiology and public health. And what I learned was working not just with individual, working at a system-wide level is where real change can be made for millions of people. So they're the ones who encouraged me to do medicine. I then went into medicine and managed to get myself, I managed to sort of, start doing some work. I got my exams, got into medicine, and then started working with the vascular epidemiology within the vascular world. And I think one of my strengths is because I learned to speak very late, and I had significant communication skills issues. My brain was kind of wired differently to what other people do. So I still had to solve the problems that everybody else faces, and I still had to do the things that other people do. But because I did it so late, I had to work at my own way of doing it. And what that means is whenever anybody gives me a problem, I think like normal people. I come out with rather strange and unique ways of doing things. And that I think, enabled me to be able to see a problem in a slightly different way can sometimes just give you the little edge to understand what the issues are.
Sometimes they say, you're sitting there and you're not speaking till 5 years old. It gives you a lot of time to really be able to observe and process, whereas other people are so, worried about just what are they going to say? What are they going to say? What are they going to say? You're sitting back and just going, well, I can't say anything. So I'm just going to sit back and process. And that's probably a skill set that you still have today that led you to such success with your program. But I'm curious, why PAD? Why peripheral artery disease? Because across the globe, it is one of those underdiagnosed, underacknowledged diseases, and particularly here in the United States, they even say that more than 70% of people, the general public polled across the US, don't even know what PAD is. And I would assume it would be the same in your area. So a lot of doctors would want to go after the big name diseases, the one where there seemed to be a lot of notoriety and people paying attention. But you went into something that's very elusive, but also a disease that is more prevalent and deadlier than most cancers combined. Why?
Absolutely.
Why PAD?
Yes. Why PAD? So I'm a vascular surgeon by day, as you mentioned, and as a vascular surgeon, I do all the things that a vascular surgeon does. So operate on carotid arteries, I do aneurysms, I do lower limb bypasses, and occasionally I do amputations as well. I do a load of venous work as well. And so why vascular surgery first? Number one is because you've got the breadth of surgery. You've got really big, somebody's bleeding from their aorta, they got ruptured aneurysm, we need to do that. And then you've got the intricate, really deep, sort of fine surgery within the foot, for example, where you have to put stitches, less than a millimeter apart, and you have to use magnifying loops to be able to do those procedures. And the reality is that, as you mentioned, very few people know what peripheral arterial disease is, but everybody knows what an amputation is. And 3/4 of vascular work is lower limb. It is foot ulcers. it is leg ulcers. But everybody was concentrating on aneurysms and other conditions where you've got this massive public health problem which nobody was focusing on. So I think my interest was vascular epidemiology first. I looked at the data. I said, what is the actual problem that we have? And that is peripheral arterial disease. And that is something we can do something about, because peripheral arterial disease, as you're aware, is atherosclerosis. It's the same disease within the heart that gives you angina. So angina is what you have in the heart, but claudication is the same disease, but it's in the legs. So it's exactly the same disease, just it's in a different place. And I think being able to explain that to patients and knowing that, with peripheral arterial disease, that's where the disease presents first. And most of the people have a heart attack afterwards. So you treat peripheral arterial disease, you prevent a heart attack later. So I think very few people were doing it, but it was a massive problem. And then once we started doing it and we've got the results, I think that's where the interest increased. And I guess finally, for my doctorate, I analyzed 100,000 amputations across England over a 10-year period. And I analyzed 350,000 revascularizations. So I had a database which has 93 million rows of data and 1,000 columns of data. And I broke the server 3 or 4 times when I was running analyses. And what I found was there were huge inequalities in amputations. So within England, the amputation rate was 30% higher in the north of England compared with the south. It was 70% higher in the Black population compared with the white population, and 3 times higher in men compared with women. Whereas the prevalence of the disease is the same in all of these populations. There is huge inequality of outcomes. And because people understood what amputations are, and people understand inequality. So now that you've got the language of inequality and you've got a problem that people can understand, i.e. amputations, we've now got the language that we can use to speak to politicians, to service leads, say this is what we need to fix. And ulcers are the root cause of, is where the journey to an amputation most often begins. So you treat ulcers, you prevent amputations, and you change the inequality that is within this great country.
And so, can you elaborate on the 4 main projects within MARS, as you call it, the acronym? Move more, reduce inequality more, diagnose more, make every contact count more, and talk about their specific impacts.
So the way we reduce amputations is the idea of you've got to reduce the risk factors for chronic disease. Therefore, you reduce the number of ulcers, and that will ultimately lead to reduction of amputations. And it's a whole systems approach. So, the idea of it takes a village to raise a child. So it takes a city to reduce amputations. So you need everybody working together. By that I mean public health, community services, hospital services, the academia, so within universities, and you need finance, procurement, and digital guys. You need everybody together speaking the same language. So with Move More, the idea is you need to reduce the risk factors for chronic disease. So within that principle is 3-4-50, which is the 3 lifestyle behaviors contribute to 4 conditions that lead to over 50% of deaths. So the 3 lifestyle behaviors are smoking, poor diet, lack of exercise. Those contribute to 4 conditions, which is cardiovascular disease, respiratory disease, type 2 diabetes, and cancer. And between them, those 4 conditions lead to over 50% of deaths. So the idea of Move More is how can we get the population to simply move more by, use within the everyday life, walk more. Understand that moving more means it doesn't mean just going to the gym. That's not where often people move more. It's about walking to the shops, using the stairs, things like how can you incorporate it within your life? So that's Move More. Reduce inequality more is around, can we make the services much more appropriate to patients? So then one of the big inequalities within England is that everybody talks about diabetic foot amputations, quite rightly so. But half of all major amputations are in people who do not have diabetes. So if you've got a foot ulcer and you do not have diabetes, you cannot access services for patients that patients with diabetes can access. So if you're a diabetic foot ulcer, you need good infection control, you need good offloading, you need good blood supply. And if you're diabetic, you can get into those services. But if you're a non-diabetic with a foot ulcer, you need those same services. But because you do not have diabetes, you cannot access them. And
We have
that's an
that same problem
inequality.
here in the US where I have a patient that we had to spend $450 out of our coffers to help through the Global PAD Association because the patient, he was on Medicaid and he's not diabetic, but he has a foot ulcer. He needed an offloader shoe, and we ended up having to buy it because he couldn't afford it and insurance wouldn't cover it simply because it wasn't a diabetic ulcer. And that's very frustrating. So that's something that you're working on there.
So that's a massive inequality. And so, I mean, within England, as you know, within the NHS, you don't pay for your service. You get it all free. But the service is set up for diabetics. So you can pay your taxes, but you still can't access the service. And that is simply wrong. And the
So you
reason
just
for
don't
that
get one at
is,
all.
well, exactly. And
Wow.
so that unfairness is a systematic unfairness. And that's because somebody's made a decision that we'll just treat diabetics, we will not treat non-diabetics. Whereas where you actually look at the numbers, whilst the risk of an amputation is greater with if you're diabetic, the actual number of people with PAD is actually greater than the number of people with diabetes. And the number of people with ulcers who are not diabetic is about the same as the number of diabetics with ulcers. So although the prevalence is different and the risk is different, the actual numbers of amputation and actual numbers of ulcers are the same within the population. Therefore, they need the right access. So we've been working with commissioners to get them to commission services different, as well as getting clinicians on the ground to understand, why are you missing non-diabetics, where half of all amputations are in this population. So if you just concentrate on diabetics, you'll only ever have half a solution to reducing amputations. So that's the Reduce Inequality More program of work. The
And
Diagnose More,
diagnose
sorry,
more.
yeah. And the Diagnose More is around teaching podiatrists and nurses to be able to assess vascular disease early and refer patients earlier to a vascular surgeon. And that's about doing toe pressures, ABPIs, recognizing the signs and symptoms of vascular disease. And then finally, the Make Every Contact Count More is one of my other hats I wear is that I'm the lead for the aneurysm screening program within Greater Manchester. So we screen 18,000 men aged 65 every year. We do an ultrasound scan on them on their abdomen to see if they've got an aneurysm. We discharge 99% of people and do nothing more with them. So the idea is, why don't we do more? Why don't we check the blood pressure? Why don't we check the feet? Why don't we check other risk factors? Are they moving more? No. Why don't we get them? Why don't we get them to improve their risk factor profiles? And that's what Make Every Contact Count More is about. We've got a program where we invite 18,000 men every year. Why don't we make that as a systematic program to improve their risk factors? Therefore, the benefits will be seen 5, 10 years down the line. So those are our 4 programs of work, working with the sort of prevention, ulcer care, and also with the hospital as well, to make sure that patients get revascularized appropriately and quickly.
You know, I'd love to say you make it sound easy. It sounds really complex, and I'm certain that there have been a lot of challenges that you have faced, a lot of resistance along the way. Would you mind talking about some of those key challenges that really stood out to try and bring this diverse group of individuals together, such as public health, community representatives, and various medical specialties?
One of the problems is siloed working. People only see their own part of the world, and they think that their part of the world is the most important part of the patient journey. Nobody sees the whole picture. And so, so as a vascular surgeon, we do the complex work within a hospital, and we think we're the most important people within a patient journey, which as a surgeon, I'll say, of course we are. The people in the community, the podiatrist, will say, well, I'm the most important person. Whereas the finance guy will say, I've got all the money, I can't spend any money. Oh, truly, I'm the most important guy. And we all know the finance guy is the guy who ultimately has all the power. So the first thing I had to do is get everybody together and just to talk to each other and just say, okay, what is the actual data? What does the data say? What are we trying to do? And once they all agreed what the problem was, I then had to say, right, okay, the finance guy, what is the problem that you need to fix? Which is usually, I need to save money. So I need to speak to him in a language that he understands or she understands, which was, how much is it going to cost me? How much am I going to save? All that kind of stuff.
It
The
all comes down to
podiatrist,
money.
yeah,
Yeah.
exactly. And the podiatrist and the clinicians will say, hang on, we're already busy. We cannot do anything more. We are run off our feet. We've got other competing priorities. I can do no more. I've got no skills. I don't have the time, all this kind of stuff. So the problem is not lack of knowledge. The problem is, I'd say, knowledge mobilization. How can we get people to understand that they need to be able to um, work better for the patient and do the right thing for the patient within a pressurized environment?
Mhm.
And so what we had to do is work with team to understand how can we increase capacity without increasing cost, and can we do it within existing resource? And the way we did that is work across the team, say, okay, what are you doing that only you can do? And what are the things that you are doing that you don't need to do that somebody else can do? So you've got to work with individual team members, understand what their skill sets are and what is their USP, what is the thing that only they can do. And if there's something that they're doing that they don't need to be able to do, that somebody with less qualified can do, right, we'll get them to do it. And then we'll put that as part of your career to start stepping up. So it's about working with teams individually to understand, to get them to use their time most effectively to do the thing that only they can do. And by stopping some things that a service does that they think they need to do that they don't, and do the things that they really need to do. It's that kind of thing that allows us to increase capacity. And there's a huge amount of, I will stop talking shortly. There's a huge amount of duplication within any city or within any service. And the reason there's duplication is because people don't talk to each other. So we had to bring the teams together, understand what their network is, understand what each person is doing, and say, right, let's just streamline this. Let's just do just do what only you can do. And then it's a multiple small steps that lead to a massive change, the aggregation of marginal gains. And that is by doing that and building collaborative leadership within the people that we worked with is what ultimately led to our headline result.
So is everyone on board in Manchester? Or are you still trying to poke the bear in some other areas that you just can't seem to get them to budge?
Yeah. So Manchester is made up of, obviously there's Manchester City, but it's made up of 10 localities, 10 areas with over 3 million people, which means there's 10 different ways of doing the same thing. And we're
Yep.
working our way around the teams. And what we can demonstrate is where we've been working effectively, things are better. And where we've not worked yet, things haven't changed. And so once people have seen the data and they've seen the truth, and then we say, listen, this is your problem. You are head of this service. Our data says that you are not improving as well as somebody else. Sometimes you just got to embarrass people into working, people who use that service. And so it's about understanding what ticks somebody's box, what kind of drives them. And so, yes, there are some areas which are more difficult than others, and we don't have the time or the resources to work with everyone at the same time. But we are, where we are working, we're having huge impacts. That data is getting published. We are
Yeah.
becoming publicized, and now people are coming to us to say, listen, help. How can we do this better?
I mean, a 40% plus reduction in amputations, that's a really big number. And you would think that people would be just knocking on your door every single day saying, hey, how do we do this? What are the protocols that you're using? Do you have this entire Mars project in a bottle that we can implement?
And short answer is yes and no. So the principles of Mars are the same no matter where you are, but how it looks in a particular area will vary depending upon local services, local personnel, local skill sets, and what you can use and how much money people have got to, implement new devices, new ways of working, and things like that. So the principles are the same, but how it gets changed is different. And a lot of the cost is just buying people's time to learn new stuff. And when you've got a pressurized service where you don't have the money to spend on people, that is often one of the barriers. One of the other barriers, sadly, is people are often a bit embarrassed. They don't want to be told what the truth is. They don't want to know the reality of their service. They think that everybody thinks they're doing a great service, and when somebody comes on the outside and say, "Listen, you can do better here if you really try," and here's somewhere else that's worked better. If you're a good manager, people will say, listen, yeah, of course, yeah, coming in. And those are the people that are coming to us naturally. Where there's resistance, I think there's a reason for that resistance, and there's a reason for the service not being as good as it can be. And for those, we need a slightly different approach, which is much more of a top-down approach.
Yeah, the one challenge that we have had, in your area is how do we get those referrals to you from other places in that area that are not, um, performing at the advanced rate that you are in terms of amputation reduction. And we've had several patients that have been on deck for amputation, and we struggle with getting the GPs to make the referrals to a facility in which Mars is implemented.
Absolutely. So, I mean, it's the service within England, as I guess with other areas as well, it is geographically based. The funding for a particular service is for a particular locality. And if you live outside of the locality, getting referred in is difficult simply because there is a finite amount of resource. But patients do have rights for a second opinion. And if they go to a certain place and say, listen, I don't feel I'm getting the right service, I want a second opinion, it is that patient's right to get a second opinion. And sometimes they can refer themselves to a service, but the GP should really refer to somebody else if that patient wants a second opinion.
Yeah, no, I agree. And we really struggle with that, especially when we try to go outside of that locale and the GP says, I don't understand. We have our own vascular network here, multiple doctors here. Why can't you find just one? And they don't seem to understand different doctors, different philosophies, different skill sets, different tools, techniques, whatever it might be that are leading to a reduction in amputations that they may find better results. For example, in your hospital versus theirs, they might say there's no option for you, but you might have an option. It's the same thing I see here in the US as well, where we still face even resistance from insurance companies that they don't understand that they have a set of doctors within the network, but they might not have an advanced limb saver in network that might be able to perform, let's say, that newer Hail Mary procedure known as a deep vein arterialization, where they hijack the vein into the foot in order to create more perfusion in the foot to heal the wound. So they just say your only option is amputation. And we struggle with that. And I don't know if that's also just simply the same issue, and I would imagine it is there as well. It's that education that is key. And I'm curious with Mars, what additional educational efforts are you providing to the GPs in particular, and how do we scale that across England? Because they are the gatekeepers, and we have the greatest frustration where we can't even get a lot of GPs to test for PAD. And you had mentioned that maybe there's a timing thing and being able to say, hey, if time is an issue for you, let's try to take some of the things off your plate, give them to someone else who can do them. Maybe that it requires less skills, fewer qualifications. And so you do have more time to touch the patient's feet.
That's a really important point. So I'm gonna say something a little bit controversial here, which is I don't think GPs are the right people to manage wounds, and I don't think they're the right people to diagnose PAD. What they are is the right person to point somebody in the right direction. And what we need is the program we have is we are developing is you've got GPs and you've got hospitals, but there's a middle group of community services, which is community nurses, community podiatrists that work together to form a high risk foot team. And they not only treat the ulcers within the community, but they can assess for PAD as well. And the real, I mean, the surgical techniques around stenting or bypasses or DVA, as you mentioned, they all work at the periphery. They're right at the no hope revascularization, where you need a last ditch attempt to try something where all these will work. But the reality is, if you're going to reduce amputations, you've got to work much earlier in the path. You've got to get the ulcers healed. You've got to get the chronic diseases healed. You've got to get the off-roading right. But reality, you've got to stop people from getting diabetes. And I think the whole focus of the system needs to be early diagnosis before you get ulcers. And that's where the real benefit to the system is going to be made. That, in addition to building those community teams with expertise, which we already have. We already have podiatrists, we already have nurses, but they don't have the right skill sets, and they don't have the confidence, and they don't have the backing of many surgeons or GPs or the funding to be able to see the number of people that they need. And what we have found is if we build those multidisciplinary teams in the community that both the hospital and the GP can refer into, and they take control of those wounds. And that obviously within the MD team, you've got vascular surgeons, orthopedic surgeons, plastic surgeons, all that kind of stuff. But the primary responsibility is by, for example, a podiatrist or a chief nurse or something like that. Those MDT teams are what work most effectively at scale.
Yeah, over here we have a new emerging area of medicine, vascular medicine. And I always say it's really the GPs have so much going on that once they realize that someone has some sort of chronic illness, they're not the right person. I agree. They're not the right person to be managing someone with a chronic illness. They don't have the advanced knowledge of a particular area to be able to really understand how the needle moves when it comes to statins and blood thinners, antiplatelets versus anticoagulants, and really understanding the anatomical issues that go along with these, especially vascular diseases. And you do need someone that can do that coordination between the endocrinologist, the podiatrist, the wound care specialist, and the vascular surgeon and the cardiologist. You need that center of care, which I think should be someone who is very, very familiar and has additional education in vascular medicine. And I think that that's really important. And then they can also help manage the movement. And I love that you have it as your number one pillar. It's that moving, that we got to get people moving. And I think a central vascular medicine doctor or a team approach that you've created there is really the right way to go, because they're the ones who know wholeheartedly that, you know what, this isn't working. We need to get you to a vascular surgeon stat, right?
And I think that multidisciplinary team in the middle has access to all of those services. So a patient doesn't need to go and see 10 people. It goes to one place and those 10 people are already there, and they come in and they can come in and see that patient at the same time. Plus, the other advantage of MDT working is that I get to understand a bit about what orthopedics do or what plastics do or what the medics do. So there's that spread of knowledge as well between the specialties, and people know what to do. GPs have their place, as I'm sure, because there's treating, it's not just the ulcer you treat. You've got to treat the leg, you've got to treat the bones, you've got to treat the muscles, you've got to treat the cardiac system, the respiratory system, the mental health system, plus where they live. Do they live in an area where they are socioeconomically deprived, where they can't move more, they can't go out because it's actually quite dangerous to go out. So there's all these other issues as well. And this is why the idea of it takes a city to reduce amputations is so important. So you got to link healthcare with general socioeconomic development as well. You got to work with the council to understand around jobs, around transport, working with the local supermarkets as well. So it's a whole team approach. And I think the wider you get, that's why you need to be right within the heart of decision making and government.
So what advice would you have for patients who are tuning in, who are really struggling with their leg pain, their leg cramps, and getting the care they need? What are the protocols that they need to be aware of? What are their rights to ensure that they are getting the proper management of PAD across England?
So I guess is we've got to get a diagnosis of what you have. And if you think you've got PAD, that does need to be diagnosed. And you should see a GP or somebody to be able to take a history and take a test to confirm that you've got PAD. And that is your right. If you think you've got something, to see a GP and get that tested, that's fine. And at some point, you've got to have to place some trust in someone. And if you feel that you don't have trust in that clinician for whatever reason, it is your right to get a second opinion. And I think that is the key thing. Just because somebody says something, hopefully they're usually right. You know, they've been to medical school, they've got various training, they should be right. But if you're not happy, you do have a right to get a second opinion. And that goes for a surgeon as well. And as surgeons and as doctors, we have to be able to say, I'm not sure, or I don't know. I need a second opinion. And often I refer patients to colleagues for second opinions as well, just to either just say, listen, have I got this right? And I think the system needs to be able to look at itself, and scrutinize itself. And patients do need to have the confidence to be able to say, listen, I'm not happy. I want to go somewhere else. And that is their right.
So as you receive this award, what do you see as the most critical next steps in advancing limb preservation excellence across England and beyond?
I think the key thing is to understand the inequality within the service. I think to be able to level up care to the diabetes standard is where we need to go. Half of all amputations are in people who do not have diabetes. So if you can level up care to the diabetes standards, everybody gets the same level of care. I think that is what's going to make the most difference. But that has to be not at the cost of diabetes care. We cannot compromise the care for diabetics in any way. We just need to expand services to those patients that need it.
You are so passionate about this. There has to be probably any number of stories of patients that have gotten the care that they needed through your program, and they have their legs today because specifically your program. Is there any one patient story that truly stands out that if you're having a bad day, you just think of that person and you think of their story and it just fires you up and keeps you motivated and keeps you going despite any challenges you may face along your journey?
A great question. So one of the faults of being a surgeon and surgeons in general is that we don't often grade ourselves by our successes. We often grade ourselves by things we haven't done correctly or things that could have gone better. And I was speaking to one of my colleagues to say, you know what, certain case hasn't gone so well, and he said to me, "What about your successes?" He asked me this question. I said, "I don't really think about them." He goes, "That's because your standards are so high. You've got to you've got to take your wins. You've got to understand what your wins are." And I think for me, one of the cases that keeps coming to mind is that of a young lady in her 40s with a young child who had lost a couple of toes and was looking at losing her leg. And one of my colleagues referred her to me because I do what we call pedal bypass. So I do a bypass right into the foot itself, into one of the small foot vessels. And he referred her to me. I did some various tests, and I thought, right, I think she'd be a good candidate for a bypass. 7 years later, she's still got a leg. She still looks after her kids. Her kids now gone through school. And that kind of thing that really keeps him going. Young women. And there's another father who kept his leg and was able to walk his daughter down the aisle. And I think that those kind of stories, when I think about it, are the ones that sort of make me happiest. And I think as a personal thing, and sometimes you do have to sit back and think, maybe I have done some good. But as a surgeon, one of the issues, and one of the reasons I like public health, is that as a surgeon, you're helping individuals, which is great. But we need to work at scale, and we need to think about a city level or a country level or a world level, because that's where the differences are. As I'm sure amongst diabetics, every 20 seconds somebody has an amputation across the world. Somebody's having an amputation, and that is mostly unnecessary. And if we just get the treatment right, we can prevent so many.
So share a case with a big lesson for you and others. Describe the patient, the frustration with the case, and the lesson that you learned and others could potentially learn from it. And it could be a success, but I have a feeling you're going to go for that failure. So you could have even used a little ingenuity in the case, whatever it might be, but go ahead and share a case with a really big lesson for you and others.
I think the case that really changes, one of the cases that changed me was a young man. He was about, I think, in his sort of mid 40s, late 40s, early 50s, who was a smoker, and he has smoked since he was 6 years old. And he smoked for a good 45 years of his life, and he had, really severe claudication. Started developing rest pain as well, and I had an honest to goodness conversation with him to say, listen, there are people who smoke till they're 80 or 90 and nothing happens to them. You are not one of those people. You are one of these people that if you do nothing, your leg is already struggling. And there's a good chance within the next 5 years, you will lose your leg. Although statistics say there's a 30% chance you will lose your leg within the next 12 months. I then said to him, your choice is simple. Cigarettes or your leg. You cannot have both. That man has smoked for over 40 years of his life. And that day, he actually took the cigarettes out of his pocket and pressed them up and put them in the bin. He goes, doctor, today, you're the first person who has spoken to me in that way and told me the reality and of what this actually, what this actually does. He actually stopped smoking. We managed to do an angioplasty on him, got him out of rest pain. Um, he then got a dog, started walking the dog, completely turned his life around. And I saw him a couple of months later, and he felt so much better. He was richer. He had loads more money. He was walking more with his dog. He's playing more with his kids, and he just felt his life was a lot better. And I think, for me, one of the powers that we have as a surgeon is when you give somebody lifestyle advice as a surgeon, some people take it a lot better than if, say, a podiatrist says it or their family says it or somebody else says it. Sometimes something from a doctor is it just carries a bit more weight. You're saying the right thing to the right person at the right time. And I think for me, it was just that conversation that just brought the reality home to him, and he completely changed his life. And I think that when I saw him again, I was like, yeah, that was good.
So the lesson there, that's beautiful. That's actually the first time a physician has actually taken that question in that direction. And I absolutely love it. How critical the conversation is with a patient and how powerful that can be, even more powerful than just manually clearing the arteries. It's empowering the patient to be a true partner in their care.
And I think that's the key thing, because anything we do, a bypass or an angioplasty, the effects of that is undone by cigarettes. It's undone by their own lifestyle. So, you got to meet me halfway here. If I'm going to do all this, you've got to do something as well for your own benefit. And I think, that conversation, that one-to-one relationship that we have with patients, I think
Yeah.
that is grossly undervalued. As a surgeon, you think that, it's my hands that do all this. It's not. It's who you are. And there's an old saying that if you speak from the mouth, it goes to the ears, but if you speak from the heart, it goes to the heart. And I think sometimes as a doctor who is genuine about a patient's, getting them better, sometimes it just hits the right note at the right time. And that to me was that conversation, that relationship, I think, was so important.
We've talked a lot about early diagnosis and the importance of that. We have a series called Journey to Diagnosis, and it runs as a separate segment. Please share a case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. Or you could even share a story of a patient whom you couldn't believe that this patient has had these other procedures like a spinal fusion for these textbook symptoms of PAD that never relieved those symptoms. And all they needed was a PAD diagnosis and proper treatment for that.
For
Too many to
me,
count.
too many to count. What often happens is patients will have an ulcer in their foot or some sort of infection in their foot, and somebody say, right, I'll just amputate the toe. Simple, amputate, get rid of the patient, get it sorted, and they're out. But then that wound doesn't heal. And that one amputation becomes a transmetatarsal amputation, which itself doesn't heal. And then they may lead to a more proximal amputation, and they ultimately lose their leg. And I've met several patients, and this annoys me every single time, where the surgeon has not done, or a doctor has not done a simple vascular assessment to say, right, this wound, the reason why this toe has gone this way is because of diabetes and a poor blood supply. They'll just see an infection, take it off, think it's all done. They see it the day after their surgery, think, okay, that's doing all right. We'll send them home, and that doesn't heal, and they come back and they just go through that cycle again. And you just wonder, listen, this patient's a diabetic, he's a smoker, he's this, he's that. All the bells that should have been ringing, right? Why did you not do a simple vascular assessment? Why did you not get a vascular surgeon involved? Why did we not do something sooner? And I've seen multiple patients that have had an amputation that simply didn't need one, where it just wasn't caught early enough, it wasn't diagnosed early enough. And that's amongst health professionals who should know better. And if you talk to them, they will talk about having symptoms of claudication before their toe went off, or that kind of stuff just gets me every single time.
Yeah, here in the States, we had a study that recently came out that talked about more than 60% of amputations for PAD are being performed without a doctor even trying. But what's worse than that is 90% of those, a proper vascular evaluation wasn't even performed prior to the amputation. And that's exactly
Yeah,
what you're experiencing there.
no, absolutely. So we've got some similar data from England that says something very similar as well. And if you look at people who've had an amputation, did they have any vascular procedure beforehand? Less than a quarter of people have had something vascular before an amputation, and you just kind of wonder why. It's just a fear, particularly in diabetics. I mean, it can be slightly harder with diabetics because they sometimes may not feel claudication or ischemic rest pain similar to non-diabetics, and so you just need a bit of clinical nuance and intelligence here, or just a bit of common sense. Somebody's older, they're a male, they smoke, of course there's going to be a vascular component to it. Come on, guys. So that does. I'm getting a bit animated here, but I think that's it's
I love
important
it.
to be able to, that kind of stuff always annoys me.
Well, it annoys me that we still have this reliance upon symptoms, textbook symptoms of claudication, and that we still classify, the claudicants, because we have patients that are in the asymptomatic phase, but it's not a textbook symptom, so we label them as symptomatic. Every one of my patients have symptoms, but they'll tell me, oh, no, 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 I don't get the cramping. I'm like, but your foot is cold and your leg is fatigued when you walk. Oh, but I don't have the cramping. Well, lo and behold, literally a month later, they're getting a toe wound, right, on their foot, and it gets infected, their toe goes gangrenous, and that spreads. So you go from allegedly asymptomatic, which to me means just simply they just don't have a standard textbook claudication. They're asymptomatic and they go straight to a toe step away from amputation. And that's what really frustrates me.
Oh, absolutely. And in medicine, you never say never, never say always. So, the symptoms that are classical for peripheral arterial disease are only in a proportion of people. It is the majority of people get those symptoms, but not everyone. And some people, it may sound like spinal claudication, or it may sound like a sciatic or something, but it's actually claudication, just a patient describing it slightly differently. So I think being able to think a bit laterally, being a bit more bit more house MD with some of these diagnoses, I think that is absolutely crucial.
One more question for you. This is a deep one. And I think that you've had a few moments that you've shared that would fit, but I'm wondering if there's a defining moment in your life. And it's a series called 6 Minutes That Matter that also does run separately aside from this. What are the 6 minutes that mattered in your career? It has to be a defining moment, a catalyst for change in your career, a spark that may have led you in a specific direction. It could be a conversation that you had with someone. It could be a moment in a movie, a show, a documentary. It could have even, been a moment where you witnessed something eye-opening. What was that defining moment for you?
That's a deep question. Um, what's that one moment
I can
that?
share a few examples if you want.
Yeah, if you could, yeah, just while I get my mind together, because I know it's gonna be from a film. That's what usually happens.
Yesterday, we had Dr. Michael Lichtenberg from Germany share a moment with his wife when they had just, started having kids, and he was an interventional cardiologist. Well, they have something else in angiography for, additional vascular training. And his wife had said to him, you know what? There's something that doesn't seem right. You seem like you're missing something in your career. What is that? What is your passion? It was that conversation that became the defining moment for him when he decided to pursue an additional set of training and title that led him into amputation reduction, which ultimately led him to become the interventional cardiologist of the year for 2024 for us. We had another doctor, Dr. Mahmoud Rezave, who's our US interventional radiologist of the year for PAD treatment. And he said his defining moment was with his mentor, who they were in a case, and Dr. Rezave said, "Hey, I don't think it could be done." And the mentor said, "Let me give you a tip. If that contrast fluid is eking through, so can you." And that has stayed with him still to this day and has led to even more saves in his career.
Those are great examples. I guess there's two, I guess, that come to mind. One is clinical, and one is personal. And the clinical one is when I was doing what called an ultra distal bypass to the foot, and we're going for like 7, 8 hours on this, and I just couldn't get this bypass to run. I'd done a bypass, then I'd done an angioplasty, and put some thrombolysis down, put some vasodilators down, all that kind of stuff. It just wasn't working. And I was speaking with one of my colleagues afterwards, one of the senior colleagues from America actually, and he goes, with these ultra distal bypasses, when they tell you that they're not going to work, it's time to stop. At some point, you're going to have to stop. And I'd been going for 6, 7 hours at this point, and you become a bit snowblind. You kind of think, what is it that I'm not? What am I missing? And sometimes you just got to realize, you know what, it's not happening. And I think the ability to stop and call for help is for me was as an important lesson that we do a bypass, and for these ultra distal ones, you do the top end, you do the bottom end, and they work great. Once they don't work, you've got there too late. You should have done the bypass 6 months ago or a year ago, and patients got to you too late. That's why you need to intervene earlier. On a more personal note, I'm, like most surgeons, we are incredibly driven. We've got 10 things on the go at any one time. I've got 3 jobs. I've got a vascular surgeon. I'm clinical director for 2 other services, and I do some other work as well. And my wife said to me, "Listen, we're going to go on holiday. Delete your email app off your phone and delete WhatsApp. Just delete it and see how you go. And in fact, just leave your phone. If there's a problem, somebody will phone me. But I just want you just to delete the apps. And in fact, and when you're in the hotel room, just leave your phone. Just by the pool, take a book. That's all you got to do. The first 48 hours are probably the hardest in my life, where you're always checking something. You're kind of and you're just not relaxing. You're not just living in the moment. So I think when Lizzie said to me, right, delete your app, just don't do it. And then I had the best 2 weeks of my life where I properly relaxed. And I think taking time for yourself to properly recharge means that you're far better at all the other jobs that you do, and you're far better for your patients. And I think that lesson for me, and Lizzie's great. I mean, she's a nurse. She used to be my scrub nurse. And there's an old saying: your scrub nurse and your wife should have the same name, right? So that was a line that
She does.
yeah, exactly. Yeah, so your scrub nurse and your wife should have the same name. And I think that for me, where just taking time for yourself and just understanding downtime is just as important as working, because they're both that integration of work life is so important. I think those are the 2 lessons: knowing when to stop, literally in an operation, and also learning when to stop in life as well, to just properly unwind.
I love that because we recently ended up with a life on the line, and I called an interventional cardiologist here, Dr. Parag Doshi, who's world renowned for crossing CTOs in the coronary. And, if it's not urgent, of course, I might text and say, hey, are you around? Can you do? But this was like, life is on the line, no joke in this case. And I called him, and he was at the Arctic Circle with his wife. And I said, oh, Dr. Doshi, why are you answering the phone right now? It sounds like you're out of the country. He said, Kim, I know you don't cry wolf. He's like, you're like everyone else. If there's a real life or limb threatening emergency, you will call. Otherwise, I don't need to take out my phone. And it was. And we had this guy on the table with his partner and saved his life. So that's true. If there's a real emergency, they're going to call. If there's not, they'll message. And those messages typically can wait. So good for you. Thank you so much from the bottom of my heart for all you do to save life and limb, not only in Manchester, but across England. And now, internationally, I think that you're going to have a global impact. And we really appreciate all the work that you're doing, your patient-centric approach, and really giving our patients hope that there are going to be more and more doctors like you who are going to exhaust all efforts to save life and limb. And so, for all of your work, we are very proud here at the Global PAD Association to recognize your efforts and your team's efforts, and presenting you with the Limb Preservation Excellence Award in England through the Global PAD Impact Awards for 2024. Thank you so much, Doctor, and congratulations to you and your team, Dr. Nasir Ahmad.
Thank you so much.